Assalamu alaikum. Our lecture today is about the sclera and the lacrimal drainage system. Before starting, I want you to see this graph about the anterior layer of the sclera. We have three layers. We have the sclera. Anterior to it we have the episclera. Anterior to the episclera we have the conjunctiva. The scleral stroma is composed of collagen bundles of varying size and shape that are not uniformly oriented as in the cornea, so are not transparent anteriorly. The episclera consists also of a connective tissue layer between the superficial scleral stroma and the tenon capsule below the conjunctiva. We have the three pre-equatorial vascular layer. We have the conjunctival vascular layer, episcleral vascular layer, and the scleral vascular layer. We'll start about episcleritis, which is an inflammation of the episcleral layer. It is common, usually idiopathic, benign, recurrent, and frequently bilateral condition. Females may be affected more commonly than males, except possibly in children, in whom episcleritis is rare. The average patient is middle-aged. It is typically self-limiting disease and tends to last from few days up to 3 weeks, but rarely longer. Associated disease, either ocular or systemic. Ocular associated disease like dry eye, rosacea, contact lens wear, while the systemic disease like collagen vascular disease, rheumatoid arthritis, herpes zoster ophthalmicus, gout, and others. This has been identified in up to a third of patients seen with episcleritis. Infectious causes are very rare, but a wide range has been reported. Investigation of recurrent cases is as for scleritis. Episcleritis can be classified into simple episcleritis or nodular episcleritis. As you see in this image, it is simple type. It will be either sectoral or diffuse. Simple episcleritis accounts for 75% of the cases, while the nodular type, which is composed of or presents about 25% of cases, it tends to affect females, but has a less acute onset and more prolonged course than the simple variant. Usually those patients with simple or nodular episcleritis presented with redness and discomfort. On examination, we'll see redness, which may be sectoral part of the episclera involved, or maybe diffused redness. We have tender red vascular nodule in nodular type of episcleritis, almost always within the interpalpebral fissure. The treatment, if mild episcleritis, no treatment is required. Only cool compresses or refrigerated artificial tears may be helpful. Sometimes weak topical steroid 4 times daily for 1 to 2 weeks is usually sufficient, though occasionally more intensive instillation is needed. Initially, or a more potent preparation can be used with a rapid tapering. A topical non-steroidal anti-inflammatory drugs is an alternative, though may be less effective. An oral non-steroidal anti-inflammatory drugs is occasionally required. After episcleritis, we'll talk about scleritis. We'll start with the immune-mediated scleritis. Immune-mediated scleritis. Scleritis is an uncommon condition characterized by edema and cellular infiltration of the entire thickness of the sclera. Immune-mediated non-infectious scleritis is the most common type, and is frequently associated with an underlying systemic inflammatory condition, of which it may be the first manifestation. Scleritis is much less common than episcleritis and comprises a spectrum from a trivial and self-limiting disease to a necrotizing process that can involve adjacent tissue and threaten vision. This is a very important classification of the scleritis, which may be anterior or posterior scleritis. This is the immune-mediated scleritis, anterior or posterior. The anterior scleritis may be not necrotizing, may be necrotizing with inflammation, or necrotizing without inflammation. The non-necrotizing may be diffuse or nodular. The necrotizing type with inflammation may be vaso-occlusive, granulomatous, surgically induced, while the necrotizing without inflammation involve the scleromalacia perforans. The non-necrotizing scleritis, as I said, it may be diffuse type, as in this first photo on the left side, or may be nodular. On the right photo, there is a nodule with the inflammation of the sclera. Those patients presented with the symptoms like ocular redness, progressing a few days later to pain that may radiate to the face and temple. The discomfort typically awakens the patient in the early hours of the morning and improves later in the day. It responds poorly to common analgesics. In a nodular type, there is tenderness of the globe and the appearance of a nodule, as I said, in the photo on the right side. On examination, there is vascular congestion and dilatation associated with edema. The redness may be generalized or localized. Scleral nodules may be single or multiple in nodular type. To differentiate between scleritis and conjunctivitis and episcleritis, as all those causes redness of the eye, the instillation of 10% of phenylephrine eye drops will constrict the conjunctival and superficial episcleral vessel, but not the deep plexus overlying the nodule or the sclera. So, if we are suspecting or we are not sure that this is a scleritis or episcleritis or conjunctivitis, when we apply the 10% phenylephrine eye drops, there is constriction of the episcleral and conjunctival vessel, while not the deep scleral vessel. So the redness stay there. So this is scleritis. The redness disappear. This is maybe episcleritis or conjunctivitis. The duration of the disease is similar to diffuse scleritis. More than 10% of patients with nodular scleritis develop necrotizing disease, but if treatment is instituted early, superficial necrosis does not occur, and the nodule heals from the center, leaving a small atrophic scar. Anterior necrotizing scleritis with inflammation. Necrotizing disease is the aggressive form of scleritis. The age at onset is later than that of non-necrotizing scleritis. Average is about 60 years. The condition is bilateral in 60% of patients, and unless appropriately treated, especially in its early stages, may result in severe visual morbidity and even loss of the eye. The symptoms of patients with necrotizing scleritis with inflammation: there's a gradual onset of pain that becomes severe and persistent and radiate to the temple, brow, or jaw. It frequently interferes with sleep and responds poorly to analgesics. On examination, the signs vary accordingly to the following three types of necrotizing scleritis. The vaso-occlusive type is commonly associated with rheumatoid arthritis. Isolated patches of scleral edema with overlying non-perfused episclera and conjunctiva are seen, as in the photo on the left side. There's a vaso-occlusion. It's apparent that the blood vessel occluded at this area with necrosis. The second type is the granulomatous type, which may occur in conjunction with conditions like vaginal granulomatosis or polyarteritis nodosa, as in the photo on the right side of this slide. The third type is the surgically induced scleritis, typically starts within 3 weeks of the procedure, though much longer intervals have been reported. It may be induced by any type of ocular surgery, including strabismus repair, trabeculotomy, and other type of ocular surgery. Posterior scleritis is a potentially blinding condition in which diagnosis commonly delayed, with an adverse prognostic effect. The inflammatory changes in the posterior and the anterior scleral disease are identical and can arise in both segments simultaneously or separately. The age at onset is often less than 40 years. Young patients are usually otherwise healthy, but about one-third over the age of 55 years have associated systemic disease. The symptoms, pain, does not correlate well with the severity of the inflammation. The signs of posterior uveitis may involve choroidal folds, uveal effusion, and choroidal detachment. Other signs of posterior uveitis is myositis, disc swelling, exudative retinal detachment. Also, posterior uveitis may cause proptosis. That's why it's very important to assess the posterior segment of patients with scleritis, especially the aggressive form of it. So we should not examine only the anterior segment, we should examine the posterior segment, the fundus of the patient, with dilatation, to be sure that the scleritis is not only anterior, maybe there's a posterior element. Should exclude this condition, we should examine anterior and posterior segment. Usually, when we suspect posterior scleritis, we do investigation, especially the imaging, like ultrasound, CT scan, and MRI, to show the scleral thinning. Here, in this image, we have what is known as T sign in ultrasound in patients with posterior scleritis. The important systemic association of scleritis is rheumatoid arthritis, relapsing polychondritis, also Wegener granulomatosis, and polyarteritis nodosa. The treatment of immune-mediated scleritis, topical steroids do not affect the natural history of the scleral inflammation, but may relieve symptoms and edema in non-necrotizing disease. Systemic non-steroidal anti-inflammatory drugs should be used alone only in non-necrotizing disease. Periocular steroid injection may be used in non-necrotizing disease, but their effects are usually transient. Some authorities view them as a contraindication in necrotizing scleritis. This is very important. Periocular steroid injection is contraindicated in necrotizing type of scleritis. Systemic steroids like prednisolone are used when non-steroidal anti-inflammatory drugs are inappropriate or inadequate, like in necrotizing disease. IV methylprednisolone may be used for emergent cases. Immunosuppressive therapy and biological agent should be considered if control is incomplete with the steroid alone. Now the second part of our lecture is the lacrimal drainage system. We'll talk about simple anatomy of the lacrimal drainage system. Simple anatomy of the lacrimal drainage system. To start with a puncti on the medial aspect of the lid margin, the upper punctum and lower punctum. Then there's a vertical canaliculus, then horizontal canaliculus, then the common canaliculus that open into the lacrimal sac. Then the lacrimal sac downward connected to the nasolacrimal duct. Then downward we have the valve of Hasner, should be opened in the early in life. There, then it's connected to the nasal cavity. Causes of watering of the eye, we have what is known as Epiphora, which is the overflow of tears at the eyelid margin. Strictly, it is a sign rather than a symptom. There are two mechanisms of Epiphora. The first one is the hypersecretion of the tear from the lacrimal gland secondary to anterior segment disease, such as dry eye or inflammation, or corneal, like for corneal foreign body. In these cases, watering is associated with symptoms of the underlying cause, and treatment is usually medical. The second mechanism is the defective drainage system. Due to compromised lacrimal drainage system, like an obstruction at any level of the lacrimal drainage system, that will interfere with the drainage of tear, so there will be overflow of tears at the lid margin. Congenital nasolacrimal duct obstruction. The lower end of the nasolacrimal duct, in the region of the valve of Hasner, is the last portion of the lacrimal drainage system to canalize, with complete patency most commonly occurring soon after birth. Epiphora affect at least 20% of neonates, but spontaneous resolution occur in over 95% within the first year. It has been suggested that early epiphora with resolution may be regarded as a normal variant, so this epiphora is due to delayed canalization of the lacrimal drainage system, which is known as congenital nasolacrimal duct obstruction. The signs we will see on examination: there's an epiphora and matting of the eyelashes, may be constant or intermittent. We'll continue with the signs. First we said there's epiphora, matting of the eyelashes, may be constant or intermittent, may be particularly noticeable when the child has an upper respiratory tract infection. Intercurrent bacterial conjunctivitis may be treated with a broad-spectrum topical antibiotic. Dental pressure over the lacrimal sac may cause mucopurulent reflex. Sometimes we have acute dacryocystitis, which is very rare. Normal visual function should be confirmed as far as possible, and the anterior segment examination with assessment of the red reflex performed. Differential diagnosis of congenital nasolacrimal duct obstruction includes other congenital disease that can cause watering of the eye, such as punctal atresia or stenosis. It is important to exclude also congenital glaucoma, chronic conjunctivitis, especially the chlamydial conjunctivitis, keratitis, and uveitis. Management of patient with congenital nasolacrimal duct obstruction, as we said, 95% may resolve within the first year. So the initial and the first step in management is massage. Massaging of the lacrimal sac has been suggested as a mean of rupturing the membranous obstruction by hydrostatic pressure. The index finger is initially placed over the common canaliculus to block the reflux, then rolled down over the sac, massaging downward. The likelihood of success and optimal regimen is undetermined. So most of those neonates, their condition will resolve with this massage up to 1 year. If up to 1 year there is no improvement, we will shift to the second step in management, which is probing. Probing means passage of a fine wire via the canalicular system and the nasolacrimal duct to disrupt the obstructive membrane at the valve of Hasner. It is usually done under general anesthesia and regarded as the definite treatment, sometimes preceded and followed by irrigation to confirm the site of obstruction and subsequent patency respectively. Reprobing may be repeated if the first procedure is unsuccessful. So, as we said, the first initial management is massaging, especially in the first year. After the first year there is no improvement, we'll shift to probing. Probing can be repeated. If probing failed, we have two other choices of a treatment. We have the celastic tubation with or without balloon dilatation of the nasolacrimal duct, and other surgery is a dacryocysto rhinostomy. Those were the most important points about the sclera, episclera, and the lacrimal drainage system. أتمنى تكون المحاضرة واضحة لكم، وأي سؤال عندكم دزولنا إياه على الموقع وإحنا حاضرين إن شاء الله. شكرا جزيلا.